Welcome to the Journal Conversations podcast as part of the Break It Down podcast brought to you by Nigeria Health Watch. The idea behind the Journal Conversation really is finding ways or creating the platform for colleagues working in the Africa public health space, thought leaders, journalists, to share opinion or dive deeper into issues, affecting us as a continent. The idea really, again, is to create opportunity for promoting learning, for cross-learning, because these issues don't affect just the country. There are always opportunities to learn. There are things to learn from colleagues, from experts in these other countries. So we felt the best people to, or one of the best persons to talk to about it would be those who are actively researching, those who are actively investigating into these issues and writing about them, right? Creating knowledge and disseminating knowledge. Journal Conversations is an opportunity to, dive deeper into these issues and gain more knowledge about them. So I'm really excited to welcome two special guests on this. Actually, this is the first edition of the Journal Conversation. This is the very first one we're doing as part of the Break It Down podcast. So I remain your host, Chibuike Alagboso, and I have two amazing people with me here, and I'll let them introduce themselves. First off, we have Dr. Bashar Abubakar. Bashar, how are you doing today?
I'm good, Chibuike. Thank you so much. My name is Bashar Abubakar, and I'm happy to join Chibuike on this podcast.
Thank you so much, Bashar. Good to have you. And I also have Muthoki. Bashar is joining us from Nigeria, although he walked across the continent, but today we'll be focusing on a piece he wrote from the Nigeria perspective. And I also have Muthoki with me. Muthoki?
Thank you so much for this opportunity. My name is Muthoki Kinthanzi. I'm a health journalist from Kenya.
Thank you so much. What was the last thing you wrote about? I mean, you should remember it. What was the last issue that you reported on or wrote a thought leadership article or a feature article or any form of story or article about? Muthoki?
So the last article I wrote was I think last week, and it's an article about how children in residential homes, or we call them charitable homes, access healthcare. And I wrote this article because Kenya just introduced a new national insurance scheme, and so I wanted to find out whether these kids would benefit from this scheme. Yeah, that's the last article I wrote.
Awesome. Bashar, can you remember the last?
Yeah, I think it was around August, September during the flooding in Maiduguri in Nigeria.
Yeah.
I think that was in August, September, right? Yeah. So, the flooding devastated the entire city. Many hospitals were really run down by the flood, and healthcare was affected, livelihoods were affected. So it was just catastrophic.
Oh.
Yeah, that's the last article. Yeah.
Awesome. So it's interesting too. So when I remember at the intro, I said the whole idea of this is to promote cross-learning. And if you look at these two issues you've written about, they are not, peculiar to either Nigeria or Kenya, right? It's these are issues affecting, both countries. These are issues affecting us as a continent, and there is always opportunity to learn. There's always opportunity to promote cross-learning, right? How is Nigeria responding to this? How are people assessing healthcare in the midst of all of these disasters? What's the child health situation in Nigeria? That, what can they learn from? What can we learn from Kenya? So really, there's always that opportunity, and that's the whole essence of this, the Journal Conversations podcast. I'm really excited to have you both here to dive a little bit deeper into issues around maternal and child mortality in Africa, right? Because this is a very big problem, persistent problem, I think is the word that I am looking for, because yes, there are efforts, the issues are there, the issues are known, but it just keeps happening. The continent contributes significantly to the global maternal mortality rate. Nigeria alone, I think about 19%, if I'm not mistaken. I think about 19% contribution, and there are so many things that can lead to maternal mortality, and of course we can't address all of it today, but we'll be honing in on a particular one, which is postpartum hemorrhage, right? Bleeding. Or I'll leave that to you, Bashar. In the spirit of breaking things down, how would you explain postpartum hemorrhage to someone who is listening or who is not familiar with what it means? Remember, the podcast is Break It Down, and we help people understand these issues as much as possible.
So thank you, Chibuike. So postpartum hemorrhage is actually loss of blood around 500 milliliter or more as a result of childbirth, or either during the childbirth or within 24 hours after delivery, and it's really one of the leading causes of death among women who are giving birth, especially in low and middle income countries. It accounts for a significant number, significant percentage of women who are dying as a result of childbirth. And again, it affects mostly women giving birth in low and middle income countries, and it's really as a result of many things, especially the lack of medications, lack of training for health workers to manage this situation. Many things really, or low quality of the medications that are being used to prevent that bleeding, that excessive bleeding as a result of childbirth.
Awesome. Thank you so much for explaining that, Bashar. And so interesting that you mentioned, the quality of medication, which is actually where we'll now be having our conversation. So there are medications that are meant to help address issues of postpartum hemorrhage. These medications are there, and sometimes they have issues around quality, like you rightly said. But could you sort of, in a nutshell, again, I'll come to you, Muthoki, to sort of learn about your experience reporting on the use of this medication in Kenya. I would like to know what the experience is in Kenya, really. What they use like. Since we are talking about maternal mortality, so give us like a perspective of what it is in Kenya.
Okay, thank you so much. So just like Bashar said, maternal mortality still remains a big issue in low middle income countries, and in Kenya, we still have high rates of maternal mortality. In fact, this is the reason why I pursued this story, because there was a health report that had just come out, and our maternal indicators were looking good. Antenatal visits had improved. Women were visiting healthcare facilities to give birth. The number of healthcare workers working in maternal care had improved. So I was wondering then, why are our numbers still high? I think Kenya, we're at 355 deaths per 100 live births, which is still high. So I wanted to find out then where the disparity is. If we are seeing all these improvements, then that should translate in lower deaths, but still our deaths were quite high. So I wanted to see where the issue is, and I found out that the issue lies in the quality, the overall quality of care, just as Bashar said. When you go to a hospital, I remember talking, as I was just doing my research before I did the story, I went to one healthcare facility, and the doctor told me that we do have medications, but our medications are not working. And so at that time, it didn't make sense to me, because I had not encountered this whole issue with uterotonic. So I did not know what she meant when saying that they have medication, but the medications are not working. So yeah, in Kenya, maternal mortality is still high. And the reason why it's still high is because of PPH. It's the one that is driving those numbers up. women are still losing their lives giving birth because of severe bleeding.
You actually took the question from, as if you saw my my list of question guides, because that was actually going to be my question. Finding out what drew you to that story about postpartum hemorrhage. Meanwhile, for listeners out there, PPH that Muthoki mentioned is postpartum hemorrhage, and Basha already explained that before, what it means in simple terms. So yeah, we'll come to that in a bit. But I'll go back to Bashar now to ask so again, I think you explained this, but just for the sake of someone who didn't understand. So these terms can be a bit confusing. So can you help clarify? So you already put them together under uterotonics as a way medications to help address postpartum hemorrhage. So you said some are injectable, some are you insert. So there is uterotonics, there is heat stable carbetocin, there is oxytocin. What's the difference? So when you say heat stable carbetocin, where does that fall in? Because for me it's also a bit confusing sometimes.
Heat stable carbetocin is another long acting oxytocin. It's like an analog. It's more longer acting than oxytocin. Oxytocin is short acting, but then carbetocin is longer acting. And also they are both used for prevention of bleeding or postpartum hemorrhage. But then it does not require cold chain. When it doesn't require freeze to be kept in the fridge or to be kept in a freezer or in a certain condition, unlike oxytocin. We get so when you talk about oxytocin, you are talking about something that is really required urgently, that will require the action urgently. But then the difference is that you also have to keep it in a freezer or in a fridge to maintain its potency. But carbetocin, heat stable carbetocin, just from the name heat stable, it can really stay out of fridge, out of freezer, and it's also longer acting. Then we have the one that is administered rectally or sublingual. When we say sublingual, below the tongue, right? Or rectally, that's through the anus. That is misoprostol. That one, usually when a health facility or a primary healthcare center does not have a fridge or does not have a freezer for oxytocin, those are the misoprostol is the next line drug that is recommended by WHO to be used for prevention or management of postpartum hemorrhage. So misoprostol we use its side effect, to prevent that. It's mainly developed for other reasons, but the one of its side effect is constriction of the uterus. So it is being. That's why some people use it for other reasons that it's not okay to mention here. But that's really the beauty of misoprostol. It doesn't have to be kept under any condition. It's a tablet. It's not given as an injection. It is given sublingual or rectally.
Thank you so much for breaking that down. Again, that's why we are here, break things down so everyone understands better. Every listener is better informed. I think I like how you explained the heat stable carbetocin, especially in our context where steady power supply is a challenge. I think you explained that too when you were giving like an overview of what these heterotonics are. They are different categories. So the ones that need storage, but the issues around power to store them, that makes the heat stable ones very, very useful. So back to you, Muthoki. So, in your quest to sort of understand that report that came out, you went to the health facility investigating, looking at what is being done. Specifically, you went to the Mukeni Referral Hospital. And so you talked about the experience with the health worker saying their medications don't work, but they have them. So could you explain some of your findings, especially relating to your story, the story you wrote that's published on the Gavi website, where you say the new drug offers hope for reducing maternal mortality in Kenya. Can you sort of help us understand what your findings were? I know you also mentioned the emotive strategy in that story. Can you help us understand, like, break that down?
Thank you so much for that question. So first I should start by explaining why I even went to this particular hospital. So a little history of its stable Kabetocin is that it was initially not available in public health facilities. It was only available in the private hospitals. So I think in 2023, the Ministry of Health and its development partners acquired this particular medication. So it was acquired, and then there is an institution in Kenya that procures this drug. So after it's been procured, then the counties, these are like states, the counties then buy this medication and stock up their facilities. So this particular hospital happened to be one of the counties that bought this medication, right? So they did it earlier on than any other facility or county. So there was evidence of impact in this particular hospital. So when I went to the healthcare facility featured in the story, I found out that the healthcare workers, especially the labor ward, were inadequately trained to respond to, or had very little skills when it comes to responding to PPH. In fact, one of them said to me that anytime a team that is attending to a mother who is giving birth, anytime the team would see a mother start losing a lot of blood, they would panic because they just didn't have enough skills and even tools to respond to PPH, right? So first, they did not have a scientific way of estimating blood loss, right? There was no way of telling if this mother has lost too much blood, right? So what they would use is just the vision estimation. They'd look at a mother and think, well, maybe she lost 500, or well, maybe she lost 400, and then from that estimation, then decide what to do. Now, the danger of this is that there's a risk of an estimation, of course, which would pose a danger to the life of the mother, right? The other thing I also got was that the cost of postpartum hemorrhage on the mothers. Remember, once a mother loses a lot of blood, they are kept in the hospital a little bit more, and they're also prescribed some medication and some special kind of diet. So all this has a cost implication tied to it, right? So this mother might not recover as soon as maybe a mom who did not experience PPH, right? Maybe this mother would have to spend a little more for medication compared to a mother who also did not experience PPH. So after Kabetocin was introduced in these particular facilities, there have been no deaths related to PPH. I should also say, alongside Kabetocin, there was also a bundle introduced called Emotive Bundle. It's just a protocol by WHO that guides a health worker on how to respond to severe bleeding. So it says things like, rub the uterine, what time you should give oxytocin. By the way, oxytocin, the country hasn't stopped using oxytocin because it's still being used for treating PPH, right? So there's also been a capacity building of healthcare workers, more healthcare workers. In fact, all the healthcare workers I spoke to were just singing praises about how the training has really helped them to know how to manage mothers better. So healthcare workers have been trained in this particular county, not just in this particular hospital, but in the whole county, all the hospitals in that county. The other thing is that Kenya now we have a measuring drip. This is a particular tool or instrument that is used to measure blood loss. Finally, our healthcare workers will not be measuring blood loss by just visual vision estimation. There are more things that I found out, but I also encourage our listeners to go and read the article. It's available on the Gavi website. Just search new drug offers hope in reducing maternal mortality in Kenya.
Awesome. Yeah, I think it's fine. Thank you so much. I mean, for me, I see this as like a two-pronged intervention. So you're able to measure, like you said before, it used to be visually, no way to know the actual amount of blood loss. Like Bashar, I think Bashar put a figure to it at the beginning when he was explaining what postpartum hemorrhage is. I think 500 mil was the number, if I got that correct. But so what you are saying now, Muthoki, is in Kenya, or specifically in the hospital, they are now able to find a way to measure, so they actually know when it's getting serious, when there needs to intervene, and then there is the intervention where they now have the medication to actually address the bleeding. Awesome. I mean, this also applies to us in Nigeria. Like I said, these issues are cross-cutting. So you did a piece back in 2018, a thought leadership article where you said, this thing is life and death, really, and why it's important to maintain the quality of oxytocin, the standard and the quality, and how it can save a woman's life during childbirth. So this 2018, that's almost 7 years now. Or that's 7 years now. So what do you think has changed since that time? What's the situation? Because I know then there was a research that you looked at around the quality of oxytocin. What do you think has changed, or things are still the same after 7 years? 7 years after you wrote that article about the need to maintain the quality of oxytocin. Basha?
Yeah, thank you. So if I can remember the article you are talking about, I think it's an article from a research that was supported by US Pharmacopoeia.
Yeah,
where Dr. Chioma Ejekam of University of Lagos Teaching Hospital really led a team of researchers to assess the quality of oxytocins in health facilities. Where it was found that about 74% of the oxytocin ampoules in those health facilities were below the standard. You get? So if 74%, that's almost 3 out of 4. So that means at that time when the research was conducted, you could just say that 3 out of 4 oxytocin ampoules there were in circulation were of substandard quality. And imagine those ampoules being administered to a pregnant woman or to a woman that is giving birth, and it may not work. That's one of the striking reasons. But the most striking worry from that research, which I wrote about, was that I think about 50-something% of the healthcare workers that participated in that research, they didn't know the storage condition for oxytocin.
Wow.
Yeah, so a healthcare worker that is administering the oxytocin, I think about 50-something, if they don't know the storage condition, how will they be able to store it? So this, and I think the research was conducted in hospitals in urban centers, So imagine those primary healthcare centers in rural health facility. In rural communities, which they are usually low cadre health workers, usually community health extension workers or auxiliary nurses that are there, or auxiliary midwives. Sometimes in some of these health facilities, I've been to health facilities when I was working with Nigeria Health Watch. I've been to primary healthcare facilities where the health workers really were just secondary school graduates. You get? So, do you think they will know the storage conditions of oxytocin if these healthcare workers do not know the storage condition of oxytocin. So it was a striking finding, to be honest. What has changed
Yeah.
from 2018 to now? So I think another follow-up research needs to be conducted to find out if the oxytocin ampoules in circulation now are of good quality. That is one.
Absolutely.
Yeah.
Yeah.
But then without that research, we need to also look at what makes them substandard in 2018. And has that situation changed now? In my personal opinion, I will attribute it to one, lack of electricity, two, lack of refrigerating system in the health facilities, right?
Yeah.
Has electricity improved that significantly between 2018 and 2025? I don't think so. I think it has remained the same or maybe even gotten worse than it was in 2018. Another one is the refrigerating system. Do health facilities now have more refrigerating systems than they had in 2018 when the research was conducted? I'm not sure, even though many health facilities now use solar powered refrigerating systems.
Yeah. Absolutely.
Yeah, but then that in a significant number, like what percentage of health facilities really have that now? Yeah, it's an improvement no matter how small it is, but I don't think it's that big. I don't think that many health facilities have that system now. Then
Yeah.
health workers, how many health workers have now been engaged and trained on um, on storage condition of oxytocin, and even not only oxytocin, there are many medications that are really required to be kept to have to have a special condition of storage, not even storage, transportation, because most of these medications are imported. So when you import them at the port, from the port, or from the airport to the health facilities, in what vehicles are they transported in? Do those vehicles have refrigeration system where these medications are kept? And let's say you are transporting them from Lagos to Abuja, or Lagos to Enugu, Lagos to Kano by road. How do you ensure that in that process of them being transported to the warehouses or to the drug distribution stores, how do you make sure that the transporting system is refrigerated enough for them to maintain their quality between Lagos and all distance I mentioned? And when you get to the
Yeah.
warehouses, are those warehouses also refrigerated? All it's a whole chain of event. From manufacturing to transporting to distribution to the health facilities where they are being kept before they are being administered. Has there been any big change from then to now? I don't think so. Then I'm not sure if the health workers that participated in those research have been engaged and trained on storage condition of oxytocin and other medications.
Medications.
Yeah,
Yeah.
yeah. So not
Wow.
sure if much has changed between then and now, but like I said, I think a follow-up research needs to be conducted to ascertain that.
Yeah. Thank you so much, Bashar, for sharing that and insights from that piece you did following that report. I think I was just looking at the report. One of the things that really surprised me, one of the things you also pointed out there was the fact that 41% of health workers or health providers in Lagos State, I think that's where the research was focused on. They have used oxytocin dose that was higher than WHO recommendation. For me, I was like, wow, that's something. But anyway, as we wrap up, I'm sure there are still lessons in as much as things are not where we want them to be yet, but definitely they are not where they used to be. So again, the idea for this journal conversation is to find things that we can learn and really learning. I think the way we see learning, yes, we always want to learn something that is good, but you can also learn from failures, right? What is not working. So I'm sure as we, listen to each other, hopefully experts and practitioners in the public health space, in both countries listen to this podcast. They are learning from what is not working, but they're also learning from what is working, right? Because at the end of the day, they are all lessons. So if you see what someone is doing wrong, you know definitely that's not the way to go. So I think when we talk about cross-learning, it shouldn't just be focused on, oh, what are the good things that I can take away? It's also what are the bad things that I need to avoid. So I think that will be my last question to both you, Bashar, and Muthoki, as we wrap up the show today. So you, Muthoki, what but I wouldn't say what you want to take away from Nigeria. Rather, I'll ask it. So you share, what do you think? Since this conversation is Nigeria and Kenya, but really it's also about Africa. Of course, we can't bring every representative from all African countries in this particular conversation. That would have been the best thing to do, but of course, that's not feasible or realistic. So, what would be your message to other African countries, not just Nigeria in this case, on what they can take away from Nigeria, and also what they shouldn't take away? Like I said, it's also about what's not working that they should, avoid. From insights from that story you did or reports you did, but also insights from being in this space and reporting in this space and following developments, and conversation from, happening in that space since, for the past 5 years. I know you did that story last year, but yeah, essentially, what do you want others to learn? It's okay.
What I'd want other countries to learn from Kenya is that they shouldn't give up. And I'll explain it this way. When I was doing research for this story and even doing the interviews, it occurred to me that it took a very long time for this drug to finally be available to our mothers, right? Took a very long time. Even from the development partners who are involved, they told me this process it's a long process, right? It's a long process to have a drug available in even a hospital, right? It requires a lot of discussions, it requires a lot of protocols. It is just a very long process, but none of them gave up. Those that were involved in this process, I mean, they would fight sometimes, they wouldn't agree, but the motivation or the desire to procure this drug was sustained throughout these years, right? And I think that is commendable. So I'd like other countries to push on. For the ones that have not acquired this drug, push on. Even if you acquire a small, what is it called? Consignment. Push on, right? Something that I would also like other countries not to pick from Kenya, it's probably the opposite, that they should not wait for so long to lose so many mothers before they can act. In Kenya, our maternal mortality rate is at 355 per 100 live births, which means we are among the highest countries when it comes to maternal mortality. I think WHO envisions a maternal mortality rate of 70 or less per 100 live births. So we're still in the high side. So that we had to wait for so long before we got this life-saving, crucial drug, before we trained our healthcare workers, before we even got an instrument to measure blood loss, is just disheartening. So other countries that are still waiting, please stop waiting and act. We should not still be losing our mothers to severe bleeding. Bringing forth life should not mean losing it as well. Thank you.
Thank you so much, Muthoki. It's really sad. We shouldn't be having those conversations in 2025, but unfortunately, that's where we are. But we keep pushing to change the narrative and never give up. Bashar, final thoughts on what the other African countries can take away or not take away from Nigeria?
So, I think they are just too much, so many things are just in my mind based on what countries should not take away from Nigeria when it comes to maternal health or health systems, primary healthcare systems in general. So I think one key takeaway is that we should stop focusing on vertical interventions, for me, in healthcare. So we have many programs. Let's say in Nigeria, you have many programs. This one is addressing this condition. This one is addressing this condition. This one is addressing this condition. But when you fix the system horizontally, that means you fix the entire system, it will be able to take care of the entire conditions of a human being. So let's say, for example, according to World Health Organization, about 74%, 70 or 70 something percent of a person's healthcare needs throughout their lifetime could be met at the primary healthcare center. Right? So if you fix the primary healthcare system, that's the whole of system approach. I'm happy the present Minister of Health in Nigeria, Professor Pate, is talking about whole of system approach to primary health, to health system strengthening. So when you fix the primary healthcare system horizontally, you will get to see that primary healthcare, let's say you take one primary healthcare center and make it to standard with the right equipment, with the right staff, with the right infrastructure. That primary healthcare center will be able to take care of almost 70% of health needs of the individual that is coming to that primary healthcare, including maternal health. If a primary healthcare center is well equipped with refrigeration system, it will be able to cater for oxytocin and other medications that require cold storage. If it is equipped with trained and qualified health workers, that means the health worker will know the storage condition of oxytocin and will also address to other health conditions of an individual. That is a whole of system approach. If the primary healthcare center has staff quarters on it, that means the health worker can be based inside that primary healthcare center and he or she can be called upon at any time. That means the primary healthcare center will operate 24 hours. That means at night, when a woman is in labor, she can be safely transported to that primary healthcare center to deliver, to give birth. And a skilled health worker will attend to her. That will protect her life. That will save her life from being transported to another town, which is far. And before you get there, maybe she could lose so much blood and she may lose her life on the way. So what I want other African countries to do, including Nigeria should also learn from itself, is that let's approach the health system horizontally, not vertically. Fix the health system horizontally, especially the primary healthcare center. If it is fixed horizontally, it will be able to attend to 70% of an individual's health, including maternal health. We have no business with maternal health issues in communities being taken, except for excessive cases, for severe cases, being taken, transported to towns to be attended to by general hospitals. If there's standard primary health care facility in that community, a woman can walk in and be attended to, and she can deliver safely in that health facility. So it's a whole of system approach, and I think African countries should prioritize that.
Thank you so much for sharing those thoughts, Bashar. Thank you so much, Muthoki. Really appreciate your time and the great insight you shared from the pieces you've written, but also being active participants in the public health space in Nigeria and in Kenya. Thank you so much. And so our listeners, thank you for taking the time to listen to the Journal Conversations as part of the Break It Down podcast brought to you by Nigeria Health Watch. Muthoki, enjoy the rest of your day. Bashar, thank you so much. Until the next one, do take care and stay active and always be part of conversations that affect you, that affect your healthcare. And Nigeria Health Watch provides that platform for you to engage. Please, if you have personal stories about these issues we're discussing, we're happy to, receive your insight, your stories, so we can share them, and all of it will contribute to this conversation. I remain your host, Chibuike. Thank you and bye.
Play beats.